also introduced by a good friend of mine. And since that time, we've gone back and forth. And because really, I approached Dr. Shipley because I really believe in pelvic health for all of my patients going through the menopausal transition. There's a lot, not just from the hormonal changes that occur, but just kind of where we carry our stress, things that go so like under the radar. Many of my patients do not want to talk about their urinary leakage, their fecal incontinence, or anything like that. And so I believe in bringing that conversation up to the forefront. And really, as I was starting Revival, looking for partners. So I'm so happy to be here to be talking about something that's near and dear to my heart, which is menopausal care. So, as you heard from my bio, I'm a whole OBGYN. In my residency training, I delivered lots of babies. I helped families bring their babies into the world, and it was great. And what I found when I got into practice after I finished my residency training was that we really don't get a lot of education as doctors when it comes to menopausal care. Shame on us. And I always tell the story about the first patient that I met because her story is reflective of a bigger issue that I believe in healthcare, that we tend to silo our body parts. And when we do that, we forget that we're treating whole human beings. So the story is a woman that was sent to me as part of just routine well care. And if you can tell, I'm nosy. And this particular person, like during the visit, not making eye contact, just kind of going through the motions. And I knew her history. She had had a heart attack. And so finally, in true Taniqua fashion, I put my pen and paper down and I said, what's going on? Like something is amiss. I don't know what it is, but something's happening. And so what she told me was that she had been on hormone therapy, um, one of the older forms of hormone therapy. She had a heart attack. And so her doctor said, stick with hormone therapy. Okay. But no one cared or bothered to ask her how she was doing off of her therapy. And so not only was she having debilitating night sweats and hot flashes once again, but she also started having a lot of the mood changes. And we'll talk a little bit about that as we go through that this menopausal transition is really a whole body transition and not just the end of reproductive potential. And so I had to literally dig into the recesses of my brain to kind of like say, okay, I think I remember learning this. And I felt so unsure and uncertain about how to treat this patient. And I think, as someone who, like I said, from a little girl, I was the one that was holding court with all the girls in my neighborhood telling my periods. And I was like 10 and I didn't have my period yet. But I wanted to know. So 4 weeks later, she pops in, fully face made, bouncing in the door. She's feeling great, right? What that showed me was that this little nugget of information that I just happened to remember made a difference in her life. What that also told me was that I needed to do better. So that began my journey through, hello. So that began my journey through becoming what is now a certified menopause specialist or menopause practitioner through the Menopause Society, formerly the North American Menopause Society. So I've been a certified menopause specialist since 2016. So I always like to start these sessions with a little bit of level setting to understand what is menopause, what is perimenopause, how do we define it? And again, I will be critical of my colleagues in the way that we define menopause because we define it based on our reproductive cycles. It is defined, menopause, as 12 months of no menstrual bleeding. Inherent in that definition is that we do not acknowledge that is, if periods just stop, great, right? I have a 13-year-old, almost 13-year-old, and I took her to go get pads, and I was like, this is for the birds. Like, these are expensive. So if it was all about just periods stopping, okay, but it's so much more. So inherent in the definition, it doesn't serve us. Median age in the United States, age 51. The transition to getting there, because for most people, you don't just have a period 1 month and then stop 12 months later and then you're in menopause. There's usually that transition, and that menopausal transition, which many people really refer to as the perimenopause, is on average 4 years. 51 median age, 4 year transition. So most people will start experiencing symptoms, which we'll talk about, at age 47, if you just go off of averages. But we know better. We know that there is a bell curve. In fact, we know that depending on your racial ethnic background, you may actually experience symptoms sooner. Not only is for Black women, for example, menopause happens earlier, so age 50 on average, and the transition then happens a little bit longer, sometimes up to 10 years. What does that mean? That means if we look at this bell curve in 10 years, when you have people say, I am 38, I'm 39, and I'm hot. My mood is changing. Something feels different. My cycles are kind of going from 28 days. Now they're 25, happening every month, but they're changing. It's the truth. So we start seeing symptoms as early as kind of like the mid to late 30s. And there are some other conditions that I'll talk about that actually can cause estrogen deficiency, if you will. That's not exactly menopause, but can sometimes show you those symptoms. So that's when we think of perimenopause. But if I get one thing here tonight, is that menopause, despite the definition focusing on menstrual bleeding, it is truly a whole body transition. We have estrogen receptors, and I speak of estrogen because estrogen is pretty much the dominant hormone during this time, all over our bodies, our brains, uterus, the gut, our bones. So as we start thinking of symptoms, we start experiencing symptoms in all of these different areas. So as an example, one of the more common symptoms outside of menstrual cycle changes, about 75% of people will actually experience vasomotor symptoms, hot flashes, night sweats. That's what we think of classically when we're thinking about menopause, right? Like the joke comedic relief on TV, the mom rips open the fridge and goes like this, and everybody's like, she's going through the change. Vasomotor symptoms, it has nothing to do with your chest. It is all in the brain. There is a center in our brain called the thermoregulatory zone of the brain in the hypothalamus, rich with estrogen receptors, rich. Well, pre-menopause, if you have a large window that you can tolerate pretty high temperatures before you feel like, oh my gosh, right? And pretty low temperatures before you feel like you're freezing, pretty wide. But as those estrogen levels decline, that window starts to narrow. So even small core body temperature elevations can actually trigger these very exaggerated responses of hot flushes. And why do we care? Sleep is truly impacted. And I don't think I need to tell, I think sleep is really big. It's like you decrease your stress, get your sleep, right? But like that's one of the first things that can be impacted, disrupted sleep, even if you're not aware of it. Like they've done studies where they've put monitors on people and they've actually detected night sweats, even when the person is not fully roused from sleep, but it does kind of kick them out of some of that deeper sleep. Okay. And so that when we think about it, it's like, well, that's in the brain. Well, there are other places in the brain. When we think of symptoms like brain fog, lots of estrogen receptors, lots of estrogen receptors in the brain in the hippocampus. What we know from the studies is that, thank goodness, when we get menopause in that first 2 years, the brain fog tends to go away. But when you're going through it, it's very rough. We know that when we have tested people specifically looking at memory scores, so they're doing complex tasks, short-term memory is usually intact. But if you have anything that requires vigilance, multi-step task, making sure you're organizing, what have you, you lose some function. It rebounds, but when you're going through it, it's pretty tough. It's pretty tough. So this is when, you have that task that requires 3 steps and you maybe get step 1 and you can't remember what you were doing. Like you went into a room, you don't know what's happening, right? That's what we're talking about. Very frustrating. And I see this especially in my patients because now let's think about it. We're in our 40s, 50s going through these. We're at the top, the height of our careers for many of us. You're high level executives or running businesses, running households, what have you. And now your brain doesn't feel like it's functioning. Lots of insecurities, lots of shame, lots of embarrassment, especially if you work in workplaces that are not menopause friendly, that you can talk about it. Look, I'm having a moment. And so that's just another thing to think about when we're thinking about this whole body transition. Another big thing that comes up, especially mood. There was a study that said about 40% of people going through the menopausal transition will have their first episode of anxiety or depressive symptoms in the menopausal transition. There's science behind it. Go back to the brain. Brain has a lot, right? Estrogen is like very great in the brain, but many of us have heard of PMS. right? Irritability, of course, some of the physical symptoms like bloating and things like that, crying at commercials, all of that stuff. You kind of laugh about it. Oh, my period's coming soon, right? And then the period comes and everything gets better. Imagine if your cycles are doing kind of mayhem nonsense. And that is like a perpetual feeling, and you don't know when it's going to go away, and you're skipping cycles, and you have no idea. And so what's happening, again, going back to the brain, is that estrogen potentiates serotonin in the brain. We've all heard of serotonin, the feel good neurotransmitter. When we think of PMS, they've studied this. As estrogen and progesterone levels plummet at that second part of the cycle, so too does serotonin. Now, for some people, they're more susceptible to it than others. That's why you have some friends that don't really have PMS symptoms, and you have some friends that it's very debilitating. And there may be some genetic susceptibility there. So, what I tend to find is that people will start having this and be like, I don't know what is wrong with me. And I tell them, and they have a lot of shame. You're yelling at your kids, you're cursing out your partner, you're cursing out your boss, right? And you're really kind of like feeling, I describe this because having been perimenopause myself, it's almost as if your real person is looking down at you and like, girl, get it together. What's going on? And I'm like, girl, right? And it's really that those drops in serotonin levels, and especially you get a lot of erratic release around this time. So I tell patients, especially if they've had a history of postpartum depression or anxiety, they've had a personal history of generalized anxiety disorder, or they've had a history of a major depressive episode, that they will be more susceptible to mood changes that can actually take them a little further than they've ever been. So for some people, they're like, baseline, I got my Wellbutrin, I got my Zoloft or whatever, I'm good. Something has changed. Unfortunately, what tends to happen, and this is kind of like what we're taught as physicians, it's like, oh, adjust the medications. But what I've learned is I trust patients. And so if I have a patient who's on this regimen and starts to say, my regimen is not working for me, I know that it's menopause. And that helps me clinically in terms of how I approach the treatment. Okay. So the other thing that people talk about, and we'll get into a little bit later, is vaginal dryness. And we're not just saying vagina to use it for sex, right? For penetrative sex. We're talking about urinary issues. We're talking about frequent urinary tract infections. We're talking about just generalized discomfort that you can't sit. Now, what we do know is that hot flashes, vasomotor symptoms, brain fog, maybe some of the mood changes even tends to get better as things settle out after the menopause, which is 12 months without a period. But what we do know is that the vaginal changes specifically, they actually worsen with time. And so it's called the genital urinary syndrome of menopause. And you'll hear a little bit more about that later. But the reason why that matters is because I have some patients that they like, waiting for my hormone therapy, and that's totally fine. But I'm always like, how's it going? Do you have an awareness of your vagina that you really don't want to have an awareness of? Because you sit, it might feel off, it might feel dry, even outside of sexual function. And in that regard, something like a vaginal estrogen is really, really helpful and very, very safe. So much so that I use it in patients who have estrogen cancers like breast cancer. And we'll talk a little bit about like, because there were a lot of questions that we got about who's the right person for hormone therapy in what circumstance. So when we get to the question time, we'll get that. Some other less common symptoms that we see, but very much related, skin and hair changes. Estrogen is great for collagen formation. So you might notice a little bit more creepy skin, wrinkles, things like that, loss of fat pads in the face, hair loss, hair thinning. We see that a lot as estrogen levels decline. We also get joint pain. There are estrogen receptors in your joints. Jeez. And so you might notice that you might have knees that hurt after workout, or you might get up and be in pain. If you were to Google right now, don't Google right now, but if you were to Google symptoms of menopause, you will get 34, 44, 100, what have you. There are a lot of things that are going on as estrogen levels start to transition and decline because it is a whole body transition. Because it is a whole body transition, that means that there really is no one size fits all when it comes to treatment. Everyone's needs and goals for their treatments are different. And so I joke, really happy that menopause is having like a renaissance, right? Because when I was like leaving residency, we weren't really talking about menopause in this way. Like I said, I was pulling things out of like a random patient that I saw in my training. There's a renaissance happening right now. There's a lot of information and not a lot of understanding of how it applies to the individual. So that's where Revival was born, to really get down to that. As I finish up, because I talk a lot.
You're good. You're totally good.
Okay, I'm good. Okay.
Yeah, the 10 minutes. Yeah.
Really?
Yeah. You're only 20. You're
I've done. As I start thinking of what are the things that I want patients to know the most about this transition, and really why I named my company Revival, coming from the Latin word which means to live again, is because we will spend over a third of our lives in this phase. So if you consider the median age is 51, the average life expectancy is like 80, we have 3 decades ahead of us. Yes, this is a transition. 100 years ago, we were
yeah.
fine, right? But we have so much that we have to live for. It's like the second act, the second phase after this like very significant reproductive transition as it's defined, but really whole body transition. So 5 things. First thing, you cannot do menopause wrong. What do I mean by that? I meet a lot of patients that feel like if they don't respond to hormones in the same way that their friends did, if they didn't like it, if they rather do this or do hormones, what have you, that in some way they're doing it wrong. And I really want to impart to you that there is no wrong way to do this. It really comes down to what your goals are, what your needs are, and how you want to function and live in your life. There shouldn't be shame about how we menopause. And I feel like that's where we're going. We're like really using hormones almost as the panacea. And for people who are like, I don't know if that's for me, it's kind of like we're being shamed. So a little bit of my soapbox, but that's the first thing. Like there's no wrong way to do this. It really is coming down to what your goals are. And when I ask patients, like, what do you want? What are your goals? No one really asks us that. What do we want? And what are our goals? It's not the way that our healthcare system is structured. It's not the way that our society is structured. So, whatever you choose for this journey, know that there's no wrong way. 2, there are safe menopausal hormone therapy treatments. Not everything is going to cause cancer. In fact, if you really dig deep into the studies that even suggested some of that, it didn't tell the whole picture. Yes, this one very specific type of hormone therapy gives one additional breast cancer, and I'm referring to the Women's Health Initiative, a 2002 study, gives one additional breast cancer for every 1,000 cases of breast cancer. That's usually the big cancer that people are most concerned about. Problem is, breast cancer is very common, very, very common. In fact, 1 in 8 women will experience breast cancer, 12.5% lifetime risk. That's really, really high. In that study, the relative risk was 20%, which really translated an absolute risk of one additional breast cancer for every 1,000. Now, if you'd have won, it's 100%. But that's just to give you the scope that there was a generation of people that went off of their hormones and really lost out probably on life because of it. So now a lot of the options have come really a long way. It's been over 20 years. What we do know is that in the study, all cause mortality was no different from the placebo group. So they had the one additional for every 1,000. But when we look at all cause mortality, there actually was no differences. And in fact, in the estrogen only arm, we saw some protective effects, which is some of the studies that you're probably seeing now about estrogen being protective for heart health, brain health, and bone health. 3, living long is not just hormones. So, new recent studies have come out that have looked at when you take hormone therapy, and some of the studies show within the first 10 years of taking it. So, the ideal time, if you choose hormone therapy, is really right around menopause. Some patients that, they're in a generation that they completely missed out and they're very symptomatic, that we will go ahead and start, but you're not going to confer the benefit if you start greater than 10 years. It might help you with symptoms, but when we're looking for like cardiovascular, cerebrovascular, like brain benefits and bone benefits, you're probably not going to like see the biggest bang there. But with that being said, there can be a role for you even outside of that. But it's icing on the cake. You still have to take care of your bodies. What does that mean? If you have chronic medical conditions, make sure that they're well managed. High blood pressure, diabetes, thyroid disease. If you are not active, movement in your life. Because aerobic exercise, according to the American Heart Association, at least 150 minutes of 30 minutes, 5 days a week, blah, blah, blah. But that has been shown to really help cardiovascular health and to also help with some of the dreaded weight gain, which we haven't touched because I know those questions, right? For that. So get a movement lifestyle going. Move your body. Practice a gratitude practice for your body. Because sometimes we don't like the body, but it has carried us this far. And so when we look at it, control your chronic medical conditions, get into a movement practice, really that cardiovascular health, because that helps the brain and the heart. And then finally, engagement. Be engaged. This being in community is everything. I think of like the ladies at the community center that have their bridge clubs, right? They live a long time. What we see, we all have that uncle, like, as it worked all his life and then he retired, he sat on the couch and then his brain went. So when we think about what are the things that matter to have this full life in this next third, take care of yourselves, move and appreciate the body, and be in community. Yeah. So I look forward to your questions because not even a tip of the iceberg. I think a little ice flake fell off, but I know we'll have an opportunity to ask very specific pointed questions in a space that's safe. And if I don't know, then I'm happy to get the information for you. All right. Thank you.